you very much. Thank you. Thank you very much. So it's interesting. So I've been to these meetings a number of times, and I guess it's kind of marked the passage of my own professional life. And so in the last 3 years, I sort of took a unique turn, and that is leaving direct care clinical practice to focus more on telehealth consulting, helping physicians diagnose and manage their patients, but also get into a number of other initiatives. And I've been able to update the community at these kinds of meetings as to what I'm doing. So, and this time I'm going to really need your help. So the talk that I'm going to give this morning is I teach, but you teach better. But just to introduce, do you want to know what keeps me up at night? What still keeps me up at night? Well, this is Welcome to Mark's Metabolic Nightmares. And so what you see here is, so this is the American Board of Medical Genetics and Genomics Certified Specialist. And the red arrows show how many of us are in this country, or how many of us have been certified. So clinical biochemical genetics used to be what it was to be a metabolic geneticist, and then that's become more laboratory oriented. So if you're going to run a metabolic laboratory, that's the kind of training you get, and that was replaced by medical biochemical genetics, which is the second level, second red arrow here. And you see here that, there's a fair number here that is recorded, but if you notice that each year, every 2 years when the exams are held, you don't see sort of a progressive rise here. You see it's pretty flatlined. And I would say that these numbers here are a little bit overestimated because according to Marshall Summer, the former SIMD president, sort of reckons that there's only about 140 practicing metabolic clinicians in the United States. It's also known, and this is from our friends at Abbott, a nutrition company, that about 50% of the metabolic clinics in North America are run by physicians who actually have no formal training. They're doing it because of circumstance, because there's no one else around. Other statistics about, according to the last published incidence data of newborn screening, that was from 2006, when at that time, it was determined that for 22 diseases, 1,250 new patients a year enter the community from metabolic newborn screening alone. And that means that for 150 or 140 clinicians, that's about 107 new patients per clinician on average since 2006. So the disclaimers here, though, is those numbers are underestimates because we are screening for a lot more disorders now in 2018 than we were in 2006. And so 1,250 new admissions to the metabolic community is a 2006 number. And so certainly per year that number is higher now because there are more diseases and there are just more babies around. So confound that with this article from the Boston Globe of last October, genetics booms but MDs lack interest. And I'm going to kind of read this because it shows what we're up against. So research grounded in genetics is booming. Therapies are in the works to treat a number of rare inherited disorders from blindness to nerve disease, but there's a shortage of doctors to diagnose and treat these patients, these illnesses. During match season for medical trainees this year, just 30 of the 55 spots for medical genetics residencies in the United States were filled. So that is a big problem, and in fact, of that number, some of those trainees are actually from other countries, so they come here to do their training, and then they leave. So those trainees are not going to be available to the patient community here in this country. So the joke among us geneticists is that we are not replicating adequately. So what to do about this? Well, there's two approaches. One is we need to attract more metabolic health professionals into the field, and two, one needs to get more specialists to pick up the slack. The problem is specialists are not trained in metabolic disease, training in metabolic disease is poor in medical schools and in postgraduate training programs. It just is, for all kinds of reasons. So, but if we are going to attract more health professionals, we have to understand that we're at a disadvantage, as I was mentioning to some folks yesterday at dinner, because medical students today are savvier than they used to be. They are concerned about lifestyle, they're concerned about what they get paid, they're concerned about how much they're on call, they're concerned about how difficult the work is going to be, because they want to consider their lives. So, and so metabolic medicine does not show well, because we are on call a lot. We may be the only one in the hospital, we may be, take our beepers with us on vacation. We don't get reimbursed well by insurance, and so salaries do not run very high. So we don't show well. And for this population of potential health professionals, the promise of an interesting genetics career is just no longer sufficient. So there are a few of us now, and there's this gathering momentum on a few of us to try and take a more aggressive look at how to get people into this field. And because it's many of us, in terms of not knowing what to do, there's this sort of, this ostrich behavior of kind of burying your head and in the sand and hoping things get better. But there are many of us who are interested in developing recruitment strategies. It might be as simple as having open houses, to attract people, attract medical students or young trainees to hear from geneticists and see how genetics can impact a patient's life. It could be setting up electives where you shadow doctors at a hospital, or it could be something more, more exciting, where you actually perhaps bring medical students or young trainees to these kinds of meetings where they can meet some researchers and some families and some people working in the field to show what are the breadth of opportunities. So I and colleagues are calling clinicians and patients and families and corporate colleagues to come forward, because we all have to brainstorm together about this problem. But what else can you do? You can tell your story, and I'll get to that in a bit. So if one thing is to attract more health professionals into this field, the other way is how do we educate specialists and specialty trainees? Well, what do we know? We know that doctors are afraid of biochemical genetics. You put up a metabolic pathway on a slide, their eyes glaze over, you've lost them, and that's the end of the talk. And with the exception of yesterday, where it was really an integral part of the talk, I don't generally show metabolic pathways because people don't like them. But there's also just a lot of misinformation out there. And it's in part because you have mentors who are specialists who are basically uneducated, and they're teaching their trainees, but they don't know it, and so what the trainees are hearing don't necessarily hear it correctly either. And this is what I learned in my 4-year stint when I did a metabolic outreach that was based at Tufts Medical Center here in Boston, in the red here, and I used to go out once a month to these teaching hospitals in the Northeast. These are major teaching hospitals that had an on-site genetic service but didn't have an on-site metabolic service. So I went out there not to teach about propionic acidemia or LCHAT deficiency. They don't need to know about this. What they need to know about is, what do you do when you see a patient with hypoglycemia? What do you do when you see a patient with metabolic acidosis? And so on. When you see a patient with that kind of thing. And so that they can remember that there are metabolic problems and how do I approach it. But it gave me a lot of opportunity to see what specialists and specialty trainees will learn and what they won't. So the other thing that I learned in that is the third point here. It is really hard to change the way a busy doctor practices medicine, because what he or she really wants is to get home at the end of the day. They just want to get through their work, they want to get home because then they don't have to dictate their charts, and they want to have a little bit of family life. It's hard to get them to change how they practice medicine. So perhaps we need a new strategy. Perhaps, yes, we should continue approaching and trying to reach the specialist, But maybe we should really be focusing our efforts on their trainees. Because the truth is, who is the boss for an intern or a medical student or a resident? It's not the attending. I mean, technically it is the attending. It's really the senior resident, who they have to report to at least twice a day, every day. And if you teach, and it's much of the teaching that happens in a teaching hospital is not done by the attending, it's done by the senior resident. And so that information gets taught a lot. So if you can reach them, you can reach a lot of the doctors of tomorrow. And educated graduates. So if you can educate trainees, when they graduate, they will see practices around the country and hopefully bring that information with them. What can you do to help them with their training? You can tell your story. So why is patient teaching important? Well, so William Osler, a famous physician who sort of put a lot of thought into medical education back in the 19th century, said to study the phenomena of disease without books is to sail an uncharted sea, whilst to study books without patients is not to go to sea at all. Medicine is learned by the bedside and not in the classroom. And that is true, and that's actually the way it was for a long time in the 60s. Almost 3/4 of clinical training occurred at the bedside because patients tell you everything you need to know if you listen to them and listen carefully to them. But by 2013, less than 20% of teaching occurred at the bedside because there's imaging, there's laboratory testing technology, and conference room teaching replaced bedside teaching. But bedside teaching remains the gold standard for learning about talking to patients. You can't talk about, it's like Sheldon on Big Bang, who learned to drive a car, by an online course. I mean, you can't do that. You can't learn about talking to patients through talking about talking. You have to talk to patients and get feedback and realize, gee, I said that right, and oh, I said that wrong. And that's how you're going to learn. And that's how you learn about medical ethics, is talking it through with patients. This quote from 1980, a thorough history and physical exam can provide the correct diagnosis in 73% of cases. On average, for certain problems, over 90%. So, yeah, I mean, you can go on, you can do searches and you can do discuss, but I mean, the information is there if you can extract it from what the patient is saying. And why do patients enjoy the teaching role? Well, it can help, it can help their home care or their child's care. If they are doing the teaching and they're teaching about disease, that will help guide your care.
Dr. Korson, can you put it a little closer?
Yeah, patients develop a better understanding of their disease through teaching. The more it's like see one, do one, teach one. You experience your life, and so by teaching it, you learn more about your disease. But at the same time, you promote awareness about that disease with others. So you know your diagnosis or your child's diagnosis best. You know what has worked and what has not worked. And you probably know the research better than 99.9% of any of the doctors that you're going to be speaking with. Just by attending these meetings and listening. Sure, maybe you blend facts together because sometimes you don't know exactly what is relevant or what is important, or you can't prioritize the symptomatology, but all the information is there. So now, why is patient teaching powerful? Well, starting in 2006, I started bringing patients into the first year biochemistry class at Tufts Medical School. And then shortly after that, doing the same thing at Boston University. And what that meant was bringing in a patient, but first doing a bit of an overview of the disease from a medical perspective so that the audience could have a better understanding of what the patient was about to say. And then the patients or the parents or both would share their diagnostic journey. They would talk about living with symptoms. They would give their perspectives on therapy, talk about living with the disease. They would mention what doctors did right and what they do wrong, which was okay as long as the doctors aren't in the audience. But I taught facts, but they tell a story and people remember stories because People love stories. That's why we go to movies. It's why we read books. And what is it about storytelling? Well, there's a whole area of research on this. And there are a few principles. One, the concept of neural coupling, where...
Dr. Korson, we can't hear you.
Okay. So the concept of neural coupling, where the listener can merge the story with his or her own experience to make it more meaningful. So if a story is good and it talks about pain, or it talks about something that tastes incredibly good, then you identify with that and you start to link it to your own experience. Mirroring, so good storytelling allows neural coupling to become mirroring, where it enables the listener to actually live the events of the story, and they internalize that story. And if it's an emotional one, if it's a hard-hitting, a good emotional story, it causes a release of dopamine in the brain, which allows recall later to be better and more accurate. So, who here is familiar with the disorder of porphyria? Great. All right.
Does it count if you've heard of it?
Nope. So let me introduce Desiree. And this is with support from Rick Rodati.
Porphyria is an intoxication disorder. The abnormal metabolites 5-aminolevulinic.
Is there a video cable?
Yeah, I think there is.